to our next episode of the Hormone Café. Today, I want to talk about bioidentical hormones. I think there's a lot of confusion around this topic, so I want to go into what are bioidentical hormones, how are they absorbed, how do we use them, and what we do with them in a practical setting here in the clinic. So when we think about bioidentical, we're talking about the same molecular structure that our bodies are making and that are used to. So for example, when we think about bioidentical testosterone, it's the same testosterone that's made in our ovaries and our adrenal glands. When we're thinking about bioidentical progesterone, it's the same progesterone that's made in our ovaries. When we're thinking about bioidentical estrogen, there's actually 3 different types of estrogen. There's estrone, estradiol, and estriol. And usually when we're saying estrogen, people are referring to estradiol because that's the dominant estrogen that we have in our bodies. And then there's something called DHEA, which is a hormone made by our adrenal glands. So we'll use all of those in this clinical setting in order to help rejuvenate your hormones, feel amazing, and get your body functioning as best as possible. So let's start with testosterone. Different hormones are absorbed in different ways. So for example, testosterone works best if it's not taken orally. We want to use testosterone in something called a troche, which is a little gummy. It looks like a little square gummy, and you actually dissolve it in between your cheek and gums. And then the other best way to use testosterone is to do it topically, which means you have a cream and you put it on your skin. Because you don't want testosterone to go through your gut. You want it to go right into your system and be absorbed, not too fast, not too slowly. Testosterone has a really long half-life, meaning that it sits around in your system for a long period of time. Why would we use testosterone? I think testosterone is normally associated with men because men have a lot of testosterone, but turns out that women need testosterone too. So in our setting, if you have low testosterone, it can make you feel low libido, low energy. It can prevent you from healing properly. So we do a lot of hormone lab checks here, and we'll test your testosterone and see if it's low. And then if it is low, of course, with all things hormones, we want to start with nutrition first, and then supplements, and then bioidentical hormones, because we never want to use bioidentical hormones as a Band-Aid to cover up something that we should be fixing to the core. However, sometimes if we want the fastest possible result, we want to do all the things at the same time, right? Like work on our nutrition and our supplements and our exercise and do our bioidentical hormones so that we can get our bodies on track as quickly as possible. So when we think about low testosterone, we're thinking about building muscle mass, eating a lot of protein, and then there are supplements that can help us rebuild our testosterone like maca and DHEA. And then if your testosterone is really, really low, we can give you bioidentical testosterone. So testosterone also comes in the form of pellets and it comes in the form of shots. However, I like to do a daily dosing because that is physiologic, meaning your body makes a little bit of testosterone every single day, because we never want to just shut down the natural functions of the body. We always want to enhance them. And we also never want to be super physiologic, meaning we want to be right in the range that your body wants to see, not too high and not too low. So we don't want to give you a whole bunch of testosterone and then you're really high and then you crash and high and crash, because that will just put you on a hormone roller coaster. We want to give you a little tiny bit every single day. So we're replenishing the natural testosterone of your body, staying in that happy range that we want to be, never going too high, never going too low, but giving you enough testosterone that you can recruit follicles well, have a great egg quality, have good libido, and have a lot of energy. One thing that's really important about testosterone in fertility world is that testosterone stabilizes a developing follicle. It can also improve egg quality. So if you're somebody who has ovulation dysfunction or has lower egg quality, oftentimes we'll use testosterone to help boost egg quality and help the quality of that ovulation, because that follicle will be stronger and then it will have a better ovulation. So also with testosterone, the whole goal is not to be on it forever. We always want to have an endpoint. So usually we'll rejuvenate your testosterone levels to a place where you feel good and have a lot of energy and can work out without feeling exhausted. And then we'll make a plan to eventually come off of it so that we can support your body's natural ability to make testosterone and that you're not on it forever. So that's testosterone. We use testosterone a lot. I think you just have to know what dose to give it in, what symptoms to look for, and what labs to check to make sure you're never going too high and never going too low. The other bioidentical hormone that we use a lot is progesterone. So progesterone is a hormone that we also give in a lot of different forms. You can do oral progesterone, you can do patch progesterone, you can do cream, you can do vaginal, and you can do injection. So lots of different ways to give progesterone. One thing that we really need to know about progesterone is that we always want to use it to enhance the natural physiology of our bodies. For example, your body only makes progesterone after you ovulate. So in the beginning of your cycle, in your follicular phase, your progesterone will be really, really low. And then sometimes people will get a little progesterone surge during ovulation. And then after ovulation, that's when the corpus luteum, so your ovaries where you have that ruptured follicle, it turns into something called a corpus luteum. After you ovulate, then your body makes progesterone. And in order to diagnose low progesterone, you need to make sure that you're checking progesterone at the right time in your cycle. Because I see a ton of patients who come to me and they said, oh, I've been diagnosed with low progesterone. But if you have a really long cycle and you don't ovulate until cycle day 25, and we check your progesterone on 21, sometimes people will be told that their progesterone is low, but they actually just haven't even ovulated yet. And so then they're put on either continuous progesterone, meaning progesterone every single day, or I'll have patients come in and say, oh, my doctor put me on progesterone just starting on cycle day 14. So one thing you have to be really careful about progesterone, it actually inhibits ovulation because your body only sees progesterone after it's ovulated. So if it's seeing progesterone, it thinks, oh, I already ovulated. It's time to have a period when I have a progesterone withdrawal. So if you're taking bioidentical progesterone and you're taking it too early in your cycle before you would naturally ovulate, it can actually inhibit your ovulation. So please, if you get your progesterone checked, please make sure that you're checking it at a proper time. It's not just universally cycle day 21 in all women. Every single body's different. Some people ovulate on cycle day 9 or 10. Some people ovulate on cycle day 35. So you always want to check progesterone after ovulation because then you can get a sense of is it truly low or not. If you check it too early, then it will be quote unquote low, but it's not actually low. It's just that your body isn't triggered to make progesterone yet because it hasn't ovulated. So why do we use progesterone? Progesterone is helpful if you have anovulatory cycles, meaning you're not ovulating at all. Oftentimes we'll give progesterone to jumpstart your body back into having regular cycles again, because if you never ovulate at all, then your body never makes progesterone. So it's helpful sometimes to take progesterone on certain times of the month in order to get your body to have regular cycles again. And then once we get your body to have regular cycles, then we can get you ovulating regularly. So we'll use progesterone in cases where you don't ovulate at all so that we can help get your cycles back to regular, because you really want to help train your body how to make hormones in proper amounts. And if you don't ovulate and your body never sees any progesterone, you can get a lot of symptoms from that. Just feeling like your body's kind of in limbo, it's tense, mood symptoms, breast tenderness, unwanted weight gain, cravings, that kind of thing can happen if you don't have proper ovulation, which makes cyclic progesterone every single month. So oftentimes we'll use progesterone in that setting, or if you have what's called a luteal phase defect, meaning your luteal phase is really short, or you do have low progesterone in your luteal phase, and we measure that on your blood work. So how do we give progesterone? I usually recommend taking oral progesterone, but the biggest side effects of taking bioidentical progesterone is dizziness, drowsiness, lightheadedness. So you really want to take it right before bed. And progesterone has a very short half-life, meaning it gets metabolized really quickly by your body. So sometimes we actually have to give it twice a day, morning and night, just depending on how your body is metabolizing it and how much progesterone you need. But sometimes that morning dose can make you feel really tired. The other way to give progesterone is to give it vaginally. You can actually do it in vaginal capsules, and it doesn't have as much bioavailability in the blood, meaning if you take vaginal progesterone, it doesn't make your blood levels so high, but it has more bioavailability closer to your uterus and your ovaries because it's getting absorbed in your vaginal tissues. The other way that we'll sometimes give progesterone is through a patch, but if we're giving progesterone through a patch, that's usually if you're in that perimenopausal or postmenopausal stage and you need continuous progesterone. So if you need continuous progesterone, you can have it in a patch form or a cream form. But if you need it cyclically and you're still ovulating, you definitely want to take it either orally or vaginally. You don't want to be taking it every single day. And then there are progesterone creams. A lot of people will come to me and they'll have either yam cream, which is sometimes has some progesterone properties, or actual bioidentical progesterone cream. However, the bummer about progesterone cream, it's just really not absorbed well through the skin. It's much, much more bioavailable taken orally or vaginally. So if you're a person who truly needs progesterone, I recommend that we take it orally or vaginally. However, in some circumstances, we can start with a cream, see how your body tolerates it, and then if your body needs more progesterone, add in a pill or a vaginal, because everybody's different. Some people are very sensitive to hormones, so you always want to be feeling amazing when you take hormones. You never want to have any negative side effects, because I have some patients who come to me and they've been on progesterone for months and months, and they say, oh, I don't really feel that great. I'm having all these PMS symptoms, but I know my progesterone's low and I know it's good for me. But there's no powering through. If you're not feeling good on something, you feel like your body is fighting it, then that's just not the right dose, the right application, or the right medication for you. If you're taking bioidentical hormones, they should always make you feel better, never worse. They should make PMS symptoms better. They should make your flow better, your cycles better, your ovulation better. So those are things, if we're going to start you on hormones, that we look for, that we're actually meeting our goals, and that you're not just taking something to take it. Also, with progesterone, you want to have an end game. You don't just want to be on progesterone for years and years and years and years. So we need to be figuring out, why is your progesterone low? Is it because of your nutrition? You're not eating the building blocks of progesterone? Is it because of your gut? You're eating really well, but your gut isn't absorbing those proper building blocks? Is it because you have a lower quality ovulation? Because if your ovulation is low quality, then your body will have a harder time making estrogen and progesterone after you ovulate. So if we're doing bioidentical progesterone, we're only doing it while we're working on the root causes. We're not using it as a Band-Aid to cover up something that we need to be figuring out. So we really want to figure out, like, why is it that your body is not making a ton of progesterone? So the way usually you take your bioidentical progesterone if you're ovulating is after your ovulation or your LH surge, you wait 3 days. And the reason for the 3 days is because it takes from the time of your LH surge, it takes about 24 to 48 hours for your body to ovulate. So like we talked about, we don't want to give progesterone too early or it will inhibit our ovulation. So we want to make sure we fully ovulated. And then on that third day, we usually start our progesterone at night, because we really want to enhance our body's natural progesterone production, not use it to trick our body or shut it down. So we take it for 10 days and then we stop it. And then when our body sees that withdrawal from progesterone, we'll have a period. And so if we're taking progesterone, we also want to be measuring your progesterone levels in your luteal phase to make sure it's actually working, your body's absorbing it, we're meeting the progesterone goals that we want to see. So if we're starting on something, we want to have measurable things that we're looking for to make sure that it's actually working and it's doing what we think it's doing. The other time that we use progesterone a lot is in pregnancy. So sometimes after we ovulate, our corpus luteum in pregnancy doesn't make as much progesterone as we want. So we can use progesterone in that case to help support an early pregnancy and a growing baby. So here at Vera, the second you get a positive pregnancy test, you call, because we check your estrogen and progesterone right away. And from the very beginning, we can stay on top of your hormones. And we check it at least every 2 weeks throughout the entire first trimester to make sure we're giving all the bioidentical hormones that you need to support a healthy pregnancy and a healthy baby. So usually when we're giving progesterone, either to help having low progesterone or to help get your body having regular cycles again, we're giving it orally or vaginally. However, sometimes in pregnancy, the needs are so high that we actually have to give it as injections. Progesterone injections are compounded in oil and you give them into your skin. So sometimes they can have the side effects of being lumpy and kind of hurting and having a little lump underneath your skin. So that's why we try to do oral progesterone before we move to injections, just because sometimes injections have those negative side effects. However, it's really important to know how your body metabolizes things and how you tolerate hormones, because everyone's different. Some people do way better on injections than they do on oral or vaginal, in which case we need to find the perfect dose and the perfect route to optimize things for your body. So oftentimes in pregnancy, sometimes we can add progesterone injections if you're truly low progesterone in pregnancy. And then also in perimenopause or menopause, we'll often use progesterone because in menopause or perimenopause, our hormone production can be very irregular. We go from making hormones in this beautiful flow to making hormones very irregularly as we transition into menopause. So to smooth out some of those irregularities, we can either do continuous progesterone or cyclic progesterone, meaning we only do it in your luteal phase every single month in order to make your symptoms a lot better and make things a lot more regular and gradual and gentle, instead of feeling like your hormones are just all over the place. Also, estrogen and progesterone are best friends. So usually when we're giving estrogen, we need to either give progesterone or pay attention to your natural progesterone production to make sure that they're balanced, because we never want to have higher estrogen to progesterone ratio or higher progesterone to estrogen ratio. We really want to make sure that we're doing it in proper ratios that your body's used to seeing, so we're physiologic. And then the other hormone that we use is estrogen. Usually when we say estrogen, we mean estradiol, because estradiol is the most potent form of estrogen in our bodies. However, there are two other types of estrogen, estriol and estrone. So sometimes we'll measure those, but usually we're focusing on estradiol. So when we think about bioidentical estradiol, it also comes in multiple forms. Estrogen can come in a pill form. We can also do vaginal estrogen, and we can do estrogen patches. So when do we use bioidentical estrogen? One thing that I see a lot is patients who have really low estrogen. And sometimes patients with low estrogen actually get misdiagnosed as PCOS because they can have really long cycles or not even ovulate at all, because you need a certain amount of estrogen to trigger ovulation. So if your estrogen is just continuously low all the time and you never ovulate, you can have a really long cycle. Or if you ovulate really late, you can have a really long cycle, and sometimes people diagnose you as having PCOS when you really just have low estrogen. So when we're checking estrogen, it's really important to check estrogen before and after ovulation, because your body, unlike progesterone, it actually makes estrogen every single day. So you can give estrogen every single day because that's physiologic. That's what your body is used to seeing. But you want to know what your estrogen is doing before you ovulate and after you ovulate, before you truly diagnose either estrogen dominance or high estrogen or low estrogen. So in patients who have low estrogen, again, like all of our principles, we have to focus on the why. Like, why do you have low estrogen? Is it because you're not eating enough? We're over exercising? We're stressed and our cortisol levels suppressing our estrogen production? Is it because something's going on with our brain hormones and our brain's not talking to our ovaries properly? So when we check estrogen, we also check all of your entire endocrine system, so brain hormones, adrenal glands, thyroid, because there can be a lot of things that are affecting or suppressing your estrogen production. So if you do have low estrogen, of course, we got to work on the root causes, right? Like focusing on the nutrition building blocks to build your estrogen back up, making sure you're exercising appropriate to your specific hormone profile, and then we also want to use supplements to enhance your body's natural estrogen production. So our omega-3s and our magnesium and our DHEA can be really helpful there. And then we think about, okay, let's use some bioidentical estradiol. So if you have really low blood hormone of estrogen or really low urine estrogen, oftentimes we can give you a little bit of daily bioidentical estradiol. And we look at what that estrogen is doing to your ovulation, because you want to make sure that estrogen is not inhibiting your ovulation and then it's enhancing ovulation. And usually you want your estrogen to be at least 400 or higher around usually you want your estrogen to be around at least 200 or higher at the time of ovulation to trigger an ovulatory event. It's a little bit different body by body. So that's something that we want to look for, is that are you starting off low estrogen and then getting to high estrogen around the time that you ovulate to trigger a healthy ovulation? Because that estrogen change in the follicular phase is extremely important for a healthy ovulation. And then when we look at our luteal phase, that estrogen production and the estrogen to progesterone ratio is really important to grow a healthy uterus lining, have a stable uterus lining, and support a pregnancy or have a really healthy period. So we usually estradiol will come in an oral form, or it also comes in a cream, or it comes in a patch. And most of the time I'll have you take it in an oral form, and we start really, really low. We microdose estradiol and we measure it and we see how you're doing on it, how you feel, what your blood levels are, and then we can always go up depending on if we're meeting our goals or not. Most people really either love estradiol or they have no side effects from it. It tends to be a hormone that gives us energy, whereas progesterone tends to be a calming hormone that makes us tired. So estrogen doesn't have a lot of side effects, but it can have side effects of having headaches or mood changes if we're overshooting it and making it too high and giving you too much. So you really want to start low, titrate up on your dose to make sure that you feel amazing, have tons of energy, have a great ovulation, a really healthy luteal phase, and don't have any negative side effects from it. So usually we're going to be giving oral bioidentical estradiol. And then sometimes we'll give estrogen as a cream. However, that's usually for patients who have really dry vaginal tissues, or they have urinary issues, frequent UTIs, or frequent BV or bacterial infections, because what estrogen does vaginally when we use vaginal cream or vaginal estrogen suppositories, it actually helps grow new blood vessels. So it helps make the tissues thicker and healthier because now they have more blood flow. However, when we're taking estrogen vaginally, it doesn't have very good absorption into our entire bloodstream, so it doesn't improve our blood levels of estrogen. So if we really need a lot of estrogen circulating throughout our entire body and our blood, then we need to be taking oral estrogen. If we just want local estrogen, or if we just want to work on your cervical mucus, for example, or the dryness of your vaginal tissues, then oftentimes we'll do daily vaginal estradiol. Estrogen also has a compounding effect when used vaginally because it grows new blood vessels. It's very important when you first start taking it that you do it every single day. You don't want to just do it here and there, willy-nilly, because it won't have that compounding effect and it won't help make you feel better. So when you first start using vaginal estrogen cream, you want to use it every single day. So for example, a lot of times in that perimenopausal or menopausal state, we'll get some vaginal dryness. It can make us feel way, way, way better to do vaginal estrogen to help grow some of those new blood vessels, get that moisture back, and help our vaginal tissues feel great so we don't have to think about them every day. Also, if you have low cervical mucus, we can use vaginal estrogen in order to bring some blood flow to that cervix, see if we can stimulate some of that mucus production. Or if you tend to be a person that has frequent bacterial vaginosis or frequent microimbalances in your vaginal microbiome, we can use some estrogen to bring some blood flow to that area and see if we can get the healthy bacteria to overgrow that unhealthy bacteria and get those ratios of your vaginal microbiome healthier. So those are the different ways that we use estrogen. And then there are estrogen patches. So sometimes patients don't do well with oral estrogen, or they'll have gut issues or liver issues, or they're not metabolizing it well, in which case we can do an estrogen patch where you wear it on your skin and it gets absorbed through the skin. Sometimes in our perimenopausal or menopausal transition, we'll also do a patch form of estrogen because it gives your body a little bit of estrogen every single day, which is physiologic, which is what we want. So for example, in perimenopause, sometimes our estrogen goes really, really high and really, really low and really high and really low. And it can be a lot more irregular than it is in our years where our hormones are flowing a little bit more regularly. And so we want to give a little tiny bit of bioidentical estrogen every single day to smooth out some of those roller coaster hormones. And instead of feeling really irritable and really moody and having headaches and having brain fog and the next day having sleep issues, it can really help smooth out those highs from being so high and the lows from being so low, and give us back some of our energy, get us rid of our brain fog, get us to have regular cycles in that perimenopausal state. And then in menopause, as we transition from our ovaries making a lot of estrogen to less estrogen, we can also use estrogen and progesterone to make us feel better in menopause so that we don't have a lot of brain fog, we get our energy back, we don't have insomnia, sleep issues, hot flashes, night sweats, things like that. With all things hormones, you always want to have an end game plan. For example, our body is not designed to see a lot of estrogen every single day, all the time. It's designed to, as we go into menopause, make less and less and less and less estrogen every single day. So we do not want to be overriding the natural functions of our body. We don't want to be giving you so much estrogen that we're causing breast issues and cancer and irregular bleeding. We want to make sure that we're giving you just the proper amount that's physiologic. So in that range that your body's naturally designed to see, where we're not overshooting your estrogen and we're giving you enough where it's not really, really low, and we can help with some of those perimenopausal and menopause symptoms. So usually if I start somebody on estradiol in that perimenopause or menopausal time, we'll make a plan. So sometimes we have to titrate up their dose, make sure they're feeling good and their levels are appropriate when we check blood. And then we keep them stable so that they're feeling really good. And then we have a plan to wean off the estrogen, because you don't want to be on estrogen forever. We want to match what your body's naturally designed to do. But on the other hand, we want to make sure that you're feeling great, because you do not have to be feeling bad in the perimenopausal period. You can feel amazing, you can have great hormone balance, and sometimes a little boost of bioidentical hormones can get you there. So we also use estrogen in pregnancy. Just like progesterone can be low in pregnancy, estrogen can also be low in pregnancy. So the day you get a positive pregnancy test, you call me and we check your hormones that day, because we check your estrogen and your progesterone. So we'll also use bioidentical estrogen in pregnancy to support that growing baby, make sure we're giving the baby all the hormones that it needs, especially in the first trimester when your ovaries are making hormones, to have as successful of a pregnancy as we possibly can. So we use estrogen in a lot of different ways, but we always want to make sure that we're working on the foundation, we're working on the root causes, and we have a game plan. We're not on it forever. We have a plan to come off of it eventually and let the natural physiology of our bodies take over. And then another hormone that we'll use sometimes is something called DHEA. DHEA is a hormone that's made in your adrenal glands. And if you have low DHEA, this can also contribute to low estrogen or low testosterone, because DHEA is the precursor to estrogen and testosterone. So if you are really stressed and you're just burning out your adrenal glands, oftentimes we'll give DHEA, and DHEA is actually a supplement. You take it orally. So we'll use that to help your body process stress and help your body make more estrogen and testosterone naturally. Another time that we use DHEA is you can use it in pregnancy to also help your body make more specifically estrogen to support a healthy pregnancy. Another way that we use DHEA is you can actually use DHEA cream, similar to estrogen cream. It has some properties where it helps rejuvenate your cells and your tissues, so we can use it vaginally to help with libido, for example. So those are all the bioidentical hormones that we use and how we use them. They can be amazing, and they can be a really great part of your care plan. When we use bioidentical hormones, the goal always is that we support your natural physiology. We never use them as a Band-Aid. We use them where we're monitoring your symptoms. We're paying attention to your blood work. We want you to always feel better when you're on something and never worse. When we use them to get you healing as fast as possible while we're working on all the other things. So for example, if you're not ovulating at all, sometimes we'll give you progesterone to help stimulate your period to come while we're working on the reasons why you're not ovulating. Sometimes if you're low estrogen, we'll give you a little bit of bioidentical estradiol while we're working on rebuilding that natural estrogen production in your body. And then we always have a game plan to wean off. And then when we wean off, we remeasure your levels and make sure that they're where you want to be. So bioidentical hormones can be very powerful, very helpful. You just have to use them in line with your body and your natural physiology. You never want to override what your body's doing. You never want to give your body too much hormones that it's not used to seeing. And you want to make sure that you're doing it in a dose and a method that your body is resorbing and that makes you feel good and works with your life. Thank you so much for joining us on this episode of the Hormone Café.